I'd like to welcome our speaker for this evening. Dr. Dan Barnett has an MD, MPH, and he's a professor in the School of Johns Hopkins School of Public Health in the Department of Environmental Health and Engineering. And he's done most of his work in this field of emergency preparedness. So I welcome him tonight to share his expertise with us. Welcome, Dan.
Thank you, Mary. And thanks to MWAOHN for the opportunity to present. And Mary's a longtime friend and colleague, and I'm always delighted to, whenever she asks me to present, the answer is yes. So it's my pleasure. I'm going to be talking tonight about, as Mary mentioned, emergency preparedness with a focus on occupational health nurses and relevant perspectives on that. I wouldn't be doing my due diligence if I didn't have a set of learning objectives. I promise I won't do PowerPoint karaoke, as they say, but I will just quickly highlight what the objectives are for our session tonight. I should mention, if you have questions, please unmute yourselves at any time. This is informal. I will get you out on time, though, I promise, at 8 p.m. Eastern. But absolutely any questions you may have, please ask. So the learning objectives are to describe the relevance for you as occupational, that should be occupational medicine and health nursing of the public health emergency preparedness system. And by the way, the considerations there are distinctions that we'll talk about for nurses. We'll explain the functional and conceptual differences between this concept that I'm sure you've heard the term ready, willing, and able. It has particular meaning when we talk about emergency preparedness and public health and healthcare. We'll talk about something called continuity of operations planning. In a way, we're doing that tonight by the transition to Zoom with the inclement weather. So these are all things that are germane and not just for pandemics. Unfortunately, we are potentially looking at another pandemic. I hope not, but with bird flu. So we need to think very, very actively, even on the heels of COVID pandemic, of continuity of operations planning and its relevance for occupational health nurses. We're going to talk about and ask for you to ideally be able to explain the elements of effective communication in occupational health contexts with regard to pandemic preparedness and response. And last but not least, I'm going to present something that some of you may be familiar with, but I don't want to assume prior knowledge. It's a tool called the Haddon Matrix, which has been used for many years for injury prevention epidemiology. But actually, even since its inception, the creator of it, Dr. William Haddon, used it for a polio outbreak. So this has relevance as well as a planning tool. So we'll really focus on applications of these concepts tonight. This is the Public Health Emergency Preparedness System. It's was basically developed by formerly Institute of Medicine, now NASCM, and adapted from prior work. And basically, this is, as you can see here, and can you see my cursor does it work with, okay. So I'm just gonna sort of walk you through this diagram using my cursor. So this is a hub and spokes diagram here. And the idea here is that there's an interlocking set of actors or entities that are critical in any response to a public health emergency or disaster. At the hub of it is governmental public health infrastructure, which, needless to say, has been under challenging circumstances for decades. And so it's always a function of doing more with less in public health agencies. We also talk about homeland security and public safety. When we think about occupational health nurses, often this is where you would reside in the private sector, not necessarily, but in many cases. The media, academia, so subject matter experts, academia, communities, and the healthcare delivery system, which includes pre-hospital, so emergency EMS systems, as well as hospital-based delivery of care. So you can take a look at this diagram and see where you individually may fit in, and it may be more than one of these bubbles where you may fit. I mentioned earlier in the learning objectives that there's a framework that is based on the common catchphrase I'm sure you've all heard, ready, willing, and able. But several years ago, my colleagues and I published a concept paper where we highlighted the unique meanings of these terms in the context of public health emergency preparedness. And I'll take these in turn. I'm going to go out of order. The phrase is ready, willing, and able, but I'm going to start with ready and then able and then go to willing. So readiness means, do you have, for example, plans in place at your organization for disasters of different types? Continuity of operations plans, standard operating procedures, and the like. And not only do you have those plans, but do your employees know what those plans are? Otherwise, it's sort of the tree falling in the forest phenomenon, as they say. Readiness also can mean, do you have the ability to get to work if a main route of transit is closed, if a freeway is shut down due to flooding, and you have to find alternate routes to work or public transportation is unavailable. So that's what we think of with readiness. And even at the household level, we think about personal and family preparedness. And there have been many studies that have, and surveys that have looked at levels of personal and family preparedness and found them to be very low, even among healthcare workers. So it's from the macro to the micro level is when we're talking about readiness. Ability means what it sounds like. It's skills and knowledge, for example, how to use a two-way radio, how to vaccinate someone if you're in nursing, how to don and doff personal protective equipment. So these are sort of skill-based activities. But there's been this long-standing assumption that if you train public health workers or occupational health nurses or any other cohort on readiness and ability, that willingness to come to work will naturally follow. And what my colleagues and I have found for in many different contexts for many years of research is that willingness should not be assumed. And actually willingness to respond to an event can vary based on even the type of event and even based within a given person's perspective. So my willingness to come to a radiological dirty bomb response may not be the same, maybe indeed lower than my own willingness to come to work in a weather disaster. So those are really important concepts that I just want to highlight there. And the idea here is that the degree of overlap, if you will, of this Venn diagram is proportionate to the probability or likelihood of having a quality response. So that's the idea here. So we really want occupational health nurses to be, and by we, I mean the world, needs occupational health nurses and other cohorts to be ready, able, and willing to respond. And that's the context in which I'm presenting that particular slide. So just by way of background, it goes without saying that pandemic preparedness is an ongoing challenge. And as I mentioned, I hope I'm wrong in my level of concern for a bird flu pandemic, but it is a concern. So one thing to keep in mind, and again, you may already be totally aware of this, but I didn't want to presume prior knowledge, is that there are different flavors of influenza. So with COVID-19, we were dealing with a coronavirus, the SARS-CoV-2. But historically, we've seen approximately 12 influenza pandemics over the past 3 centuries. So influenza pandemics occur with a certain regularity. And the 1918 pandemic, that you may is sometimes referred to as the Spanish flu, contained elements of bird, human, and swine. It's thought to have included all 3 of those. So we often see what we call zoonotic contributions to pandemics, where different strains that come from different types of animals, they combine and infect humans, and humans don't have pre-existing immunity, and we have a pandemic on our hands. So avian influenza, that's what we're concerned about as one of the threats right now. Swine flu, you may recall the 2009 H1N1 pandemic. Well, that wasn't just swine, it was multiple species. And what makes a pandemic is geography. This is often poorly understood. So pandemic, by definition, the root word is pan, which means, in this case, global. And a pandemic is based on global infection with an agent that's highly pathogenic for humans, so causes significant disease, is genetically unique, and is easily transmitted person to person. So the concern is that if the current avian flu strain becomes easily transmissible person to person, we could, unfortunately, have the next pandemic on our hands. So occupational health nurses are at the forefront of all of these kinds of threats in a variety of ways, and we'll talk about that. So just very briefly, seasonal influenza, we can't neglect that. Obviously, we see on average approximately 36,000 deaths annually from seasonal flu alone in the US. And around the world, almost roughly 500,000 deaths each year, give or take. The highest risk groups for complications include children, so the extremes of age children or the elderly, and also those with pre-existing underlying chronic health conditions like asthma, diabetes, and heart disease. So as I mentioned earlier, pandemics should not come as a shock to us, unfortunately. And we know that there's a historicity to them. They've sort of a pattern, if you will. As I mentioned, have been 11 pandemics over the past 3 centuries. And if the bird flu strain becomes a pandemic, we will have our 12th, actually our 13th, if you count COVID-19. But we're going to focus on flu pandemics. This is a famous photo from Camp Funston in Kansas. It's a military installation from 1918, and it just shows you the enormous strain on healthcare and public health systems that a pandemic exerts. Obviously, you've all experienced COVID-19 on the front line, so I'm talking to the choir here. But this is really a major issue, and frankly, as you well know, nurses are by far the largest cohort of health providers, and without nurses, hospitals and other healthcare systems simply do not run. So I am talking to the choir here. So these are all very relevant as we think about current and future threats. So we have a little discussion question. If you'd like to unmute yourself, it's up to you. I'd love to get your input. So during that 300 years period, there'd been an average roughly of 10 to 49 years between pandemics, give or take, with an average of 24 years. So when 2009 came around, we had been due. It had been decades since the prior pandemic, since the most recent influenza pandemic. So again, this is an issue. I'm interested in your thoughts. Were you surprised? And when I say current pandemic, we are no longer officially in COVID-19 as a pandemic, but we're still seeing it, right? Were you surprised in your jobs when you learned that the pandemic was not an influenza pandemic with COVID-19, but rather a coronavirus? I'm just curious. There's no wrong answers. I'm just interested in your perspectives.
Yes.
Okay. Is that Magdalena? I just want to make sure I'm. Oh,
No, this is Diane.
Oh, I'm sorry, Diane. Diane, I'm curious. Thank you. Why was it a surprise to you? And again, no answers. It was a surprise to many of us, frankly.
Right. So it didn't come across like a regular flu outbreak, number one. We had a very high mortality rate, which was pretty shocking. The speed that it traveled around the world was also a shocker. The level of illness and the quickness of how it spread was also above what you would have considered for most flu outbreaks.
That's beautifully said. And really those are some of the main things that made this sort of a surprise to public health and healthcare. And one thing I want to highlight, and we saw this also actually with COVID-19, even though that was a coronavirus and not an influenza virus, pandemics historically have been multi-year events. So the 1918 pandemic actually was 1918 and 1919 and actually went into 1920. You may recall the 2009 pandemic was actually 2009 and 2010. And of course, COVID was a multi-year event. So I mentioned this for a couple of reasons. One is that these are long duration events and they exact a tremendous toll because of their duration on you all as occupational health nurses and the entire health and public health infrastructure. So that's one of the sort of backdrops against which we're going to discuss some key concepts here. So just very briefly, I mean, this is, you know, this cold, but I'd be remiss not to include slides like this. But, you know, when we think about pandemics, we need pandemic prevention or mitigation. We want to think about things like non-pharmaceutical interventions, you know, public health 101, hand washing with soap and water, coughing and sneezing etiquette into the elbow and not hands, social distancing, as we saw, was a paramount during COVID-19, and quarantine, which is often confused with isolation. Quarantine is just out of due diligence, is when someone may have been exposed but is not yet sick. And isolation is when someone's already sick and we're sequestering them because they're already sick. We often hear isolation and quarantine, or quarantine and isolation, is like a blurred phrase, but they actually mean two different things. They're both important, but they're different types of prevention. So we just talked about non-pharmaceutical interventions. Now let's pivot briefly to pharmaceutical interventions or therapeutic countermeasures. So we have antivirals. We saw, I think we are seeing things like Paxlovid and other kinds of sort of antiviral interventions. And going back to seasonal flu, one of the many reasons that seasonal flu vaccination is important is it reduces the likelihood of a human strain of the seasonal flu strain mixing with an avian or other species strain, leading to a pandemic strain. And then, of course, during COVID-19, we saw, frankly, lightning quick development of vaccines, thankfully, which saved a lot of lives. So the pandemic strain-specific vaccine is something we would obviously need to be mindful of for the next pandemic, whatever the type of strain it is. So let's talk about occupational considerations when we think about pandemics. And I'm focusing on pandemics tonight because I think right now, frankly, that's kind of on the forefront of, I would say, occupational health in terms of emergency preparedness. Obviously, we are seeing increasing frequency and number of severe weather events, but I just want to use this as an illustrative context, and it can be applied in other ways too. I'm sorry this slide is slightly blurry, but this is what we call continuity of operations planning. And so one of the things that you as occupational health nurses can take a lead role in, and may already be doing so, is to develop continuity of operations plans for your organization to keep things running, so to speak, in a long duration such event like a pandemic. And I'll just briefly highlight the key phases. Phase one is to create plans and we talk about all hazards. All hazards means, like, for example, we would have an incident command system chart that would be used whether we had a weather disaster or a pandemic event or the like. But the idea here is you want to create plans and procedures that address various assumptions, and you may want to have specific plans for different types of hazards. It's up to you. And actually may be a good idea, depending on the hazard profile of your jurisdiction. But certainly pandemic planning should be part of the mix, in my view. Identify critical functions and services that your organization performs, and think about how are you going to maintain those in a long duration event, for example, like a pandemic. In doing so, you'll want to identify who the key personnel are and what are orders of succession. What if, as we saw in COVID-19, frontline people become ill? Who's going to be the backup? How are we going to sort of continue to make things work in the organization? Providing data support systems and vital records, identifying alternate facilities. So that's one of the things that we have to be mindful of. We may see or need to convert different types of ambulatory facilities into pandemic care facilities. And we have to think out of the box sometimes regarding this. Identify communication systems and emergency contact information. So you're all familiar with a phone tree. It's very important to have up-to-date information and backup ways to reach people. not just their primary cell phone numbers. We know that in acute events, cell phone systems typically go down because everyone's calling everyone. And even though they call it a wireless system, there is a wired component. So we need to have multiple ways of reaching people. And that should be updated. I would recommend if you have like a sort of a data bank that you can ask people to update their information as it changes, but at the very least, you maybe do every few months a touch base or an email requesting the latest contact information. So that will aid with that. Reinforcing by education, training, and drills and exercises, and reviewing the continuity of operations plan at least annually, semi-annually, even better if you can. But it's what your bandwidth allows, but at least annually is recommended. So in many ways, if you're an occupational health nurse, as you well know, we need to think about your workplace in terms of planning and policies and resources and communication and coordination. So these are all listed here on this slide. I'm not going to read it off to you, but you can play a critical role, and I would recommend should play a critical role given your expertise in the planning, policy, resource decision-making, communicating with your employees, those in your care and your coworkers, and helping with coordination. So organizations or associations like MWOHN play a crucial role of that type of coordination. So as I'm, again, talking to the choir. So let's just talk briefly about each of these elements in turn. Planning should be done in advance of a crisis. Now, sometimes we have to do post hoc planning, meaning after an event has begun. But so it's not like you can't have a pandemic plan after something has started. And in fact, we needed to do that with COVID-19. So it's not like all or nothing. If you miss the boat, you've missed the boat. But to the extent that you can at least plan broadly, what are the key things that one would need to think about, even using COVID-19 as an experiential example for your organization, that should be done to the extent possible in advance of the next pandemic. These are some critical questions. I know that they sound, very mundane, but they're super important. So who are essential employees? That can differ from one organization to another. Who are required attendance employees? Are those the same, one and the same? Depending on the event, it may be an all hands on deck kind of response at your agency or organization. How do you identify who's essential? In terms of essential employees or required attendance? How do you let them know? Do they get special training, and what type of training do they get? Do they get hazard pay? That's a salient question. So that's something that's above my pay grade, of course, but not above yours as occupational health nurses and at your organizations, as you're all in senior important positions to make an influence on some of these critical questions. Why prepare all employees? Well, this is from a study I mentioned that colleagues and I have been researching willingness to respond for many years. And our first study, just very briefly, we looked at willingness to respond among 3 small to medium-sized health departments in the state of Maryland. To our surprise, the leading predictor of public health workers' willingness to come to work in a pandemic was how important that employee perceived their role to be in the overall agency response. So employees who perceive their roles to be important were 9.5. You see where I'm highlighting that with my cursor? 9.5, that's the odds ratio. It's a very high odds ratio, and it's statistically significant. 9.5 times more willing to come to work than their counterparts who perceive their roles to be unimportant. Why is that meaningful? Well, you can think your role doesn't matter, but you could be factually wrong. Your role matters a lot. It's just never been explained to you through training how and why your role matters. So occupational health nurses can also be at the vanguard of educating their coworkers, your coworkers, on how and why their roles matter. Out of curiosity, how many of you are on emergency planning committees at your organizations, or any of you involved with that kind of role? And if you're not, this is my humble encouragement to a call to action because you can play such a critical role. So again, this is one of those things where I feel like nurses can play such a vital role, and I just it's my humble encouragement if that's feasible, to play a role in those kinds of committees. Thinking about what are the potential impacts of travel and business operations of the event that you're thinking about. How many of you have used the incident command system? Could I get like a show of hands or in the chat box? Did some of you use it, for example, in COVID-19? Okay, so I'm seeing, yep. And so let's talk about that, because it's very important. I do a lot of trainings for health departments, and one of the key areas is incident command. And you can go onto FEMA's website, and there are various online trainings that you can do and get a certificate for through the FEMA site for incident command. And I think it's important for, frankly, everyone at an agency who's playing a role in response to be familiar with it. So anyway, that would be something to consider. Forecasting and expecting employee absences. You may have employee absences for a variety of reasons, including people are sick. So that goes back to the continuity of operations planning. And one of the opportunities, I don't like to use COVID and opportunities in the same sentence. It was a horrible experience. But it can be a learning opportunity to plan for the next pandemic, is what I'm getting at. So if you have after action reports from your organization or other kinds of follow-ons, you can identify lessons learned to help you plan for the next one. And promoting seasonal flu vaccination. So as occupational health nurses, you obviously are trusted and at the front lines of communicating the importance of these kinds of vital preventive measures. Establishing policies, that's the second. So the first was planning, the second is policies. If you, for example, at an organization, what are employee compensation and sick leave policies? One consideration is you don't just like you want someone to come in if they're able to. You don't want someone to come in if they're sick and could infect others. So the opposite of absenteeism is presenteeism, which is not a good thing. That meaning that someone is sick and shouldn't come to work, but is. So, but if people feel they're going to lose their jobs if they don't come in, that becomes a disincentive to stay home when they should stay home. So the idea here is these are parts of policies that occupational health nurses can play a role in formulating. Again, the hierarchy of controls, and this is very relevant in hospital, healthcare, workplace settings, you name it. And I'm not going to go into the weeds on this, but the hierarchy of controls, basically, there are a series of steps that that an organization or an entity can take where you can eliminate potential exposures, reduce or eliminate exposures at the source. Administrative controls is the third level, and then personal protective equipment. So ideally, the less people have to think about what they're doing, the more effective the control is, right? So the more human decision-making goes into it, the more liability or likelihood it is that someone may make the wrong choice and may imperil theirs or other safety. So all of the hierarchy elements are important, but you might want to think about how your insights as experts in occupational health nursing can provide important contributions, which can, to these various hierarchy of engineering control policies. These are HR questions. So if these weren't answered in COVID, they need to be answered soon, because whether it's bird flu or something else, unless there's a universal flu vaccine, we will have another flu pandemic or other kind of pandemic, depending on what strain we're dealing with or type of virus. Will I still get paid? I'm willing to work from home, but I don't have a job that can be done from home. Do I still get paid? Are there travel restrictions? So you can see where we're going with this. If I'm not paid, do I still get health benefits? So these are occupational health and HR intersecting considerations. Resources, sneezing and coughing etiquette. So those of you who may be familiar with Hopkins, we've had and I'm not sure they're still there, but in the hospital, they would have large posters of how to do the proper technique for sneezing and things like that. And we have a wonderful former faculty member at Hopkins named Peter Pronovost, who talked about basically the checklist approach, they use, has been used in aviation to mitigate the likelihood of things. So that relates to everything from how to avoid line infections to, how to avoid infecting others by using proper sneezing and coughing etiquette, hand washing, and other kinds of things. So allocating resources. There's a finite set of resources available to any organization. And in your expert roles as occupational health nurses, you can and do play a critical role in making many of those determinations. So again, a lot of details. I'll let you read these on your own. These will be made available. Mary's kindly agreed to put it into a PDF file for those attending. But these are things you can kind of think of this PowerPoint as a sort of a handy dandy chart or set of details of key considerations, and hopefully you'll find those useful. Cleaning and sanitizing. Before and during a pandemic, these are things to consider. Closing of non-critical common areas and maintenance of plant infrastructure. Access control. Employee and visitor restrictions. So personal protective equipment. How many of you had to do a lot of donning and doffing of PPE during COVID-19? Okay, so a number of you, so not surprising, right? So depending on the event we're dealing with, there may be different levels or required types of PPE, but these are absolutely critical elements for resource allocation. Thinking also about IT infrastructure, remote access capabilities. Telehealth has become much more advanced, but there are some things that there's no substitute for in-person. You can do some things with the aid of telehealth. There's lots of clinical aspects, but think about what are the backup plans and backups to those backup plans for resource allocation. Communication is really important. And as occupational health nurses, again, you could tell me more than I could tell you, but regarding the critical role of occupational health nurses in communicating to your patients and to your colleagues at your organizations and agencies and institutions. So we have to think about two different kinds of stakeholders or customers, if you will, your external outside of the walls of your organization and your internal customers or stakeholders, those your fellow employees. Both groups need to receive attention. Both groups need to be familiarized with pandemic fundamentals. There needs to be that plan in place. This goes back to the readiness and willingness and ability aspect. There's so many instances where there are great plans, but nobody knows what they are. And I'm not speaking regarding your organization, I don't mean that, but I've done a lot of trainings at health departments, and a lot of times I'll just ask a series of 2 questions. So is there a plan? And the directors say, we have a plan. And then I'll ask in a very, diplomatic way. A question like, so who's seen the plan? And those are often 2 very different answers. So in other words, it's not just leadership, it's line staff that needs to know what the plan is. And again, that may sound obvious, but you'd be perhaps surprised at how often that doesn't materialize. When we think about communication, we need to think about sections within your organization that you should communicate within an emergency: facilities, human resources, corporate security, IT. I'm not going to spend a lot of time on this model, but I just want to say a couple things. We've looked at willingness to respond, as I mentioned, and found that there are 2 modifiers of willingness to respond. One is perceived threat. In other words, if I'm going to ask someone to make a preparedness kit, we'll use that as an example, I have to convince someone that there's a legitimate threat worth making a kit for. So if I'm in Florida, actually it's not a good example because there was a snowstorm in Florida a few weeks ago, but if I'm in Minnesota and I'm saying you need a preparedness kit for a hurricane, that's a non-starter, right? So we need to actually have the right context to make people feel not frightened out of just to be frightened, but realize the importance of taking action. So having a threat that is motivating, coupled with what Bandura psychologists called self-efficacy, confidence that one can make a kit. And there's another term, unfortunately, has nothing to do with disasters, but it's a communication term. It's called response efficacy. In the case of making a preparedness kit, it means if I make a kit, will it actually make me safer and my family safer? If the answer is no or ambiguous, why should anyone spend money and time making a preparedness kit? Turns out that efficacy weighs more than threat in terms of training toward willingness to respond. So again, you'll have this here, but the idea here is if I were to pick one employee or a profile of an employee who is most likely to be willing to come to work in a disaster based on, and there's always exceptions, but overall, it's what we call the concerned and confident worker. Concerned about the threat and confident that they know what to do, self-efficacy, and they feel that their role in responding to the event matters in the context of their agency and their external stakeholders and communities. So that's part of communication, and that's summarized here. Obviously, we could do whole seminar series on misinformation and disinformation. This is an ongoing challenge. It will remain an ongoing challenge, unfortunately. Should we have another pandemic in the near future or otherwise? But it's important as occupational health nurses for you to be, monitoring the latest, best information. For example, the state health department or DC health department, for example. So you are on top of that information, and because you are looked to, obviously, in your vital roles as purveyors of accurate information, and people, there have been various studies and that nurses are among the most trusted cohort of health providers. So inherently, you are trusted agents, if you will. And so you can play a critical role in providing information, encouraging personal protective equipment use among your colleagues and patients. And even we talk about being sensitive to different cultural perspectives when it comes to disease and illness. Coordination, making arrangements in advance regarding coordination with agencies that are appropriate for your organization. For example, insurers, health plans, other local healthcare facilities, federal, state, and local public health agencies, other businesses. So coordination is critical. There's a long list of challenges, and this is just pandemics. But these can also, this is just for pandemics, but these can also apply to other kinds of threats. Everything from school closures to power outages to using what's called the strategic national stockpile, quarantine or movement restrictions. So all of the above present challenges in a variety of different emergency and disaster settings. I want to briefly walk us through, because I want to have time for questions that you may have. But there's a model that I think is useful. When I learned about it as an MPH student, it was a real game changer for me as I was thinking about a career in emergency preparedness. And see what you think. But this is called the Haddon Matrix that I'll describe here. This is a tool that's been around since the 1960s. It was created by William Haddon. He wasn't vain enough to call it after himself. He called it the phase factor matrix, and it was subsequently named after him. He was the original first director of what's now the National Highway Transportation Safety Administration. And his challenge that he was faced with was that that public safety messages were not making a difference in reducing highway traffic accidents and related traffic morbidity and mortality. So he sort of took a divide and conquer approach to that challenge of traffic injury and thought about, well, how can I sort of break it down, break a car accident down on the highway into before the moment of impact, which is pre-event, at the moment of impact, which is the event phase, and following the moment of impact, which is post-event. And what are the various relevant factors that at the pre-event, event, and post-event phase that relate to the host or human factors, the agent or vehicle, the car, the physical environment, the road conditions, for example, and what he called, or came to be called, sociocultural environment, for example, a rate of enforcement of speeding law or yield laws. And so this, through several iterations, resulted in what I'm going to show you here. And it's very simple, which makes it elegant. Now, there's no such thing as a perfect model or a perfect tool. in this regard, but it is a useful one, and I'll provide an example, and you can use this as a way to plan. Remember, we talked about planning as a critical role at the organizational level. So as occupational health nurses, you can help work with a group of colleagues, fellow experts, to populate this table for the potential bird flu pandemic, for example. So the phases again are the rows: pre-event, before we'll say before the hurricane; event, at landfall. I'm just using hurricane as a metaphor, but an actual example too; and post-event, after landfall. And then the various factors that come into play respectively in each of these phases are the host, sometimes referred to as human factors, human error, or human effective behavior. The agent is the least modifiable column. You can't really change SARS-CoV-2. What you can do is introduce the right personal protective equipment, the right social distancing measures, and the likes. Does that make sense? In other words, you can't do a lot about the viral agent itself once it's out there. You can, though, do things around it. And one of the other things you can do is modify the physical environment. That goes back to the example I mentioned of the hierarchy of engineering controls. You may recall that hospitals would sort of create separations so that people coming in would be sort of maneuvered so they would be less likely to infect others. That's one part of the hierarchy of engineering controls, barrier walls, those kinds of things. And then sociocultural environment, which is laws and also societal perceptions of disease and illness. And anyway, all of these things can be, and you can make a Microsoft Word table with this. You know how when you make a Microsoft Word table, the cells automatically expand? So the idea would be that you would think of a particular scenario, pandemic flu, at your organization, and how your organization would identify what the host, agent, physical, and sociocultural environment factors are at each of those three phases: pre-pandemic, during the pandemic, and after the pandemic. And you can use this approach. You can go down the rows or down the columns to develop it, or you can go across the rows. So I'm going to use a very practical example of a pedestrian injury illustration to show how the pandemic is so simple and powerful. This is intentionally a very oversimplified Haddon matrix, because theoretically you could fill lots of things in each of these cells. But let's use someone's crossing a street in DC and they get struck by a car. So we're going to take that scenario and apply the Haddon matrix to it in this slide. So before the moment of impact, before the person gets struck, the pedestrian gets struck, human factors could be maybe an intoxicated pedestrian, or maybe an intoxicated driver, or maybe both. So you want to think of all the possible things that could be relevant. Does that make sense so far? Okay. The next thing, going across the row, what would be the agent that before the moment of impact that could be relevant? Well, maybe it's a speeding vehicle, right? Force equals mass times acceleration. You'll recall that, of course, from so that's the agent or vehicle. Physical environment. Maybe it's an intersection with poor lighting. I'm just making this up. Or maybe there's a pothole. So, or both, right? This is before the moment of impact, but it's still relevant, right? But I should add that you could have the same item in multiple cells. Oops. It just manifests at different points in time. Low rate of enforcement of yield laws. No one's even been hit yet, but you're setting the stage for a potential collision with a pedestrian. Now let's talk at the moment of impact. That's the event phase. So a human factor at the moment of impact could be osteoporosis in an elderly pedestrian, right? Heightened susceptibility to fractures. The agent factor at the moment of impact could be the car front end profile. If it's a high car front end profile and you have a shorter pedestrian, that would change the whole pattern of injury, right? The surface characteristics, is it slippery? Is it, are there potholes? Is it both? Is it black ice? Whatever the case may be. And speed limits. Are the speed limits appropriate? Are the speed limits enforced? That is relevant at the moment of impact. And then post-impact, an elderly pedestrian that may, for example, if that individual has chronic underlying health conditions, may affect convalescence, The crash investigation done afterwards can allow for insights to avoid future events like that. The distance to the nearest trauma care facility in emergency medicine, there's a term called the golden hour. It's generally considered that window of time when an injury happens, a severe injury, and that person there's sort of an hour in which you can save a life. And it's not exact, but it's considered the golden hour. And is there a regionalized trauma care system? So do you see what we've done here is we've taken someone getting hit by a car and we've divided it into pre-impact and the various factors that come into play, pre-event, moment of impact and the various factors that come into play, and after the impact, post-event, and the various factors that come into play. Does that make sense? Okay, so you could easily adapt this to a pandemic scenario, right? Pre-event, event, and post-event. What are human, agent, physical, and sociocultural environment? And in fact, when applying the Haddon matrix and thinking, it's very useful as a collaborative tool. So it would, an ideal, for example, would be an occupational health nurse with an epidemiologist sitting with an administrator. Maybe you each wear multiple of those hats, whatever the case may be. But you can, within the things you fill in each cell, you can highlight or put an asterisk by the ones that you think are the most feasible and of most significant in public health influence, and choose those strategies from within the menu that you've created amongst your various cells. So this tool has been used in a variety of contexts relating to occupational health. Everything from safety belts to youth injuries to death investigation to construction injuries. So this is an occupational health tool along with everything else that we've talked about. It's scalable. You can use this at your agency or organization level, or you could use it at your state or regional level or even national level. And that's highlighted here. But any tool is only as good as the people using it, and you all are experts. So it's important to have experts like you who come from different perspectives toward a problem solving item to sort of put your minds together in a collaborative way, which goes back to that collaborative process I mentioned as part of, remember we talked about planning and policies and all that. The last element was collaboration. So the Haddon matrix is an ideal collaboration tool. And as I mentioned earlier, Haddon, even when he was putting this tool together for use for traffic injuries, he was already thinking ahead of how could it be used for infectious disease management, in this case, a polio outbreak. Okay, so the pre-event, and we think in public health terms, pre-event is equivalent essentially to primary prevention. The event phase is secondary prevention, and post-event is tertiary prevention. And it relates, there's something called, you're probably familiar with, the epidemiologic triad of host, agent, and environment. Well, when you think of the various columns, you have the host column, right? You have the agent column, which is the organism, in the case of a pandemic, that's causing the disease, and that's the least modifiable column, as we talked about. And two types of environment, physical environment, that's the physical environment column like we talked about, and the sociocultural environment column. So when we think about the next pandemic, the host could be humans, could be also birds, could be H5N1, could be others. The physical environment column could be healthcare resources, hospital infrastructure, your own institutions where you work as occupational health nurses. What are laws and societal attitudes toward illness and the like? Can't forget mental health. These are various things to consider. I will not read off the whole list, but these are things that are important to keep in mind when we think about pandemic planning. And again, I'm focusing on pandemics, but the same kinds of conceptual framing can be adapted to other types of threats, whether it's a weather-related disaster or otherwise. And in fact, my colleagues and I published on the Haddon matrix several years ago for H5N1. H5N1, so avian strains like H5N1 have been around for a very long time. And so while the potential hazard has been out there, the sort of nature of the threat that it poses can change over time. And so we are experiencing concern right now, understandably, with the avian flu strain that's circulating. So anyway, notice what we did in this. This is just like a snapshot from a table. This is the pre-event. So imagine the Haddon matrix, and you're only looking at the pre-event row. And we looked at what are the human factors, the agent sometimes referred to as vector, physical environment, and sociocultural factors. And we highlighted the ones that we thought were most feasible and could be influenced by public health intervention. Notice nothing is highlighted in the agent column, because as we talked about, you can't really do a lot about the agent itself. You can do things with the human part of the pre-event planning. You can do things for the physical environment pre-event planning and the sociocultural pre-event considerations, but this is the least modifiable column. And we did the same for event phase here. In the interest of time, and this will all in your PowerPoint, so you can take a look at this at your, at your leisure. But I want to highlight this is used, as I mentioned earlier, this can be used at many different levels of operation, including at industry, and has been used in industry. And at the institutional level. So that's why I really thought it might be helpful to include this in our discussion tonight in your critical roles as occupational health nurses. So again, just more examples. And the time to use the Haddon matrix ideally is to fill out as much as you can before an event. You can always do a save as, and should do a save as an event evolves, and see how your Haddon and update the Haddon matrix as you learn more about the threat that's playing out. So this can be a real-time planning and organizational tool. So this is where I'm interested. I've done plenty of talking already, and I'd like to hear from you. First of all, any questions you have, but here's a discussion question I'd love to get your perspectives on as occupational health nurses. So let's say a large business in your jurisdiction has requested your guidance for its institutional preparedness efforts for the next pandemic. And the question here is, and just putting on your hat in your roles as occupational health nurses, what do you think are the biggest preparedness and related resource challenges that your organization might face in readying for the pandemic, and how would you address them? So again, no wrong answers. You are experts in the front lines. I'm interested in your thoughts. What are your organizations, or what could you envision your organizations doing in preparation for a possible bird flu pandemic? And feel free to unmute yourselves or type in the chat box. I would love to get your perspectives. Okay, so I'm just pulling up the chat here.
Hi, Dan. I work in academia, not in an occupational health nurse setting, but we are starting a preparedness committee. And I think one of the things that we would have a challenge with in terms of a pandemic would just be replacing, instructors replacing other instructors. And I imagine that would also apply in any occupational health nurse setting, is and I've tried to encourage the group to have a buddy system. I'm wondering if that would be practical with my colleagues who don't work in a single nurse office.
Well, it's a great question, Jill, and I think it can be done, and frankly, Zoom can be a way to do it, to at least get people virtually face-to-face, if nothing else, in planning. So, yeah, I would not let sort of the physical boundaries necessarily be an impediment. I think the idea of what you're describing, Jill, is an excellent one, frankly, and we need lots of that going on right now. So, I would. It's a long way of saying I encourage it. That's a great approach.
But I think for the single nurse units, the administrators would have to have enough backup personnel that if there is a nurse that's out sick that day, they would have a replacement that could physically go to that unit and be the nurse, for that period of time that the person is out.
Exactly right, Mary. And that goes back to what we talked about earlier with continuity of operations planning. So what if the front line, or one person is ill? Who's their backup? Do they know that they're their backup? How do they know that they're there? And have they been just as trained as the front line? Does that make sense? To Mary's excellent point? Yeah, that's exactly right, Mary. So it's like having a bench. You know what I'm saying, in sports, because this happens. These are 2-year duration events. People get sick. and other things. So these are great comments I'm seeing in the chat box: increasing supplies, staffing, resources, and preparedness. I'm just reading these aloud. Catherine, could you describe what you mean by emergency preparedness champions? I love that phrasing.
I feel like what I mean in that regards is we have to have a specific point of contact who would lead emergency preparedness trainings, because we always think we're trained already, but when the pandemic comes, we're lost.
Great comment. Yeah, I love the word champions in that context. It's a great point. These are all great comments. Having adequate supplies, particularly PPE and staffing. You may recall at the beginning of COVID-19, there was a shortage of PPE. I mean, it seems like so long ago, but it kind of, when you think about it, early in 2020, or right after the pandemic started, there were PPE were issues, shortages were issues in hospitals. Also, educating staff, exactly, screening employees, developing protocols. Val, it will be interesting how the anti-telework sentiments of late will affect operations if people need to quarantine. Well, great question. My answer is a big question mark to that question mark. Yes, yeah, great question. So these are all salient things moving forward. So that's kind of the way that we need to be thinking, I think, just as we plan for upcoming threats, evolving threats, and the like, and in your vital roles as occupational health nurses. So thank you so much for your comments, and happy to take any questions you may have.
So, Dan, one of the things I'm thinking, this is Diane, I think every outbreak has had an opportunity to educate us on getting ready for the next one. So I think about 1981 when I was stationed in the Army in California, and we had this new outbreak of an HTLV3 virus that nobody knew what it was about. We had increased number of tuberculosis cases showing up all over the state. None of us knew what was really going on. And we didn't really have the level of antivirals that we ended up developing because we had HTLV3 HIV outbreak. So now we have the antivirals being developed, and we get to something like COVID. We wouldn't have had any of that if we hadn't already probably had HIV. I tell people that all the time when they need cold sore medicine. I said, be grateful for the AIDS outbreak, because you wouldn't have had a lot of the antivirals that you have available now.
You're absolutely right, Diane.
And I think about the same with the fact that we have no ability to work from home at the beginning of COVID. In 2020, when we all were told to go home, we had no way of doing our jobs. And there have been so many iterations. We didn't have Zoom.
Nope.
We didn't have laptops available to everybody in the organization. So a lot of things have dramatically changed since COVID. And I would think that might be helpful in the next outbreak. Now, bird flu has been a problem. I think most of the birds in Europe have been infected for years. They used to report it to us all the time. There's been an outbreak of bird flu among the birds in this country, and then they just stopped reporting it because it was so, it was so widespread. The thing that I worried me about COVID was how many iterations of the virus, how the virus kept mutating. I don't know that flu viruses mutate as much as what we saw with COVID. What are your thoughts on that?
Yeah, great comments and questions. So it's uncertain to the extent with any given viral source of a pandemic, to the extent that it will mutate. There's a genetic shift and what's called genetic drift. You can get sort of small mutations that make a difference. The amount of mutations, it can vary. So there's not, unfortunately, a monolithic response. It's a terrific question. So, but that's why we need to have active surveillance, because, as you rightly pointed out, Diane, during COVID, the pandemic, we had several different strains. And, it was like whack-a-mole, like once we had one strain that we thought, then there was another one. And that was that whole year of 2020, that awful year where we didn't have anything in terms of vaccination options and no immunization options. So that's a long way of saying it's a question mark.
I think surveillance is really going to be important for the occupational health nurse because we're seeing all of these reporting requirements are now down. We're not having things reported to the CDC so that we can track these viruses and these illnesses. So when people return to work, they usually come back to the occupational health nurse to be cleared for duty. And I think it's going to be important for us as nurses to kind of, be the eyes and ears for the next pandemic.
That's exactly right, Mary. You may recall the anthrax, the first cases of, remember inhalational anthrax with the mailings after 9/11. The earliest cases were detected in Florida by an alert clinician who saw something on an X-ray that didn't look right. So he saw something called mediastinal widening on the chest X-ray, and the patient didn't have any other reason to have mediastinal widening. So my point is that, and I tell this, and I talk about this in my various courses that I teach. We can have all the fancy AI in the world, but ultimately it's the alert clinician who's going to pick it up first, or at least among the very first. So
Right.
to Mary's point, that's exactly right, and speaks to your excellent comments, Diane, too.
Well, I want to thank you so much, Dan, for this excellent presentation. Really enjoyed it.
Thanks very much.
Okay, if anybody has any questions, you can send them to me. I can get them to Dan. And also I'll be sending out evaluations tomorrow for everyone by email. So just look for that in your inbox. I don't have a name for Zoom user. Everybody else, I have their first and last name, but I don't know who Zoom user is. So please either speak up now or send me an email so I can get you your evaluation tomorrow. And I will send out copies of the slide deck to everybody tomorrow as well with the evaluation. Okay. Thank you, everybody.